Hello, everybody. This is Mark Lynn with Healthcare Business Specialists in Chattanooga, Tennessee. We'd like to welcome you to the third of, excuse me, 4, maybe 5 of these RHC billing webinars. Today's date is January the 23rd, 2020, and this is sponsored by Azalea Health and ChartSpan, who are our partners working with rural health clinics to provide seminars and webinars for you guys. Here is a picture of me and my contact information if you do need to get a hold of me. Dani Gilbert is on the line as well, and she will be running some poll questions for us today. There is her contact information if you need to get a hold of her. Louise Burkhead is here from Trinity Medical Clinic. She is a member of the billing staff there and does a fantastic job with those. And Cammi Jones is here. She is with Commonwealth Health Management, and she just muted her line. So that is good. If you will double check your lines and make sure they're muted for some reason, go to webinar. Yesterday was leaving lines open, even though in theory they should have been closed, and was getting a lot of feedback yesterday.
Hey,
so
Mark,
yes,
I actually had to mute Cammi because the dialing was coming through hers, so I need to unmute her so she can mute herself.
Okay, all right, that sounds good. All right, Cammi, Dani's going to take care of you, and we appreciate you coming along for this webinar today as well. Do remember, we do have seminars. They're free thanks to Azalea and thanks to ChartSpan. So please save the dates for those. Here's what the seminars will look like. And then Cammi, if you will mute your line, that would be really helpful.
Or they'll be contacting you. Do you get all that stuff?
Yeah. Dani, do you want to mute her line until she back on there to mute it? Thank you. Okay, here is what we do. We have a listing of services there, cost report brochure. We do program evaluations, emergency preparedness. Dani does TennCare reports for you guys. So it is getting cost report season. We would love to work with you if you're an independent RHC on your cost reports. If you've not joined our RHC information group, we went over 1,000 members today. So thank you very much. We've really grown from 850 members to when I did this post a couple months ago to over 1,000. So I think people are finding that to be very, very useful, the group. And I know people are getting questions answered just about every day, maybe 2 or 3 of them. So do that. Do remember January the 29th, 2 to 3 p.m. there is going to be a webinar by Nathan Baugh from the NARHC on changes for reimbursement during the year and regulatory changes. So hopefully again we can get a news about $115 rate for independent RHCs. That would be nice. And then we are doing a cost report webinar next week as well. So keep that in mind, put that on your save the date for that webinar, and then we will go from there. Questions or comments, you can type your questions into the sidebar over there. We will provide some time at the end for you guys to ask questions, and we will have poll questions as we go through and let you guys answer those questions as well. Disclaimer, everything was up to date as of a couple of days ago. This session is being recorded, and so if you have an issue with that, you're welcome to go, but I don't know why we have to say that, but we do. Let's go ahead and get started. This is where we left off the other day. We talked about the QVL, the Qualified Visit List, and Medicare did away with updating that. It's still a good guideline for you guys to use, but if your HCPCS code is not on that listing, then it's perfectly fine for you to bill that to Medicare and cross our fingers, hope that it will pay. It died October the 1st, 2016. So your first question of the day, Dani, if you'll go in and open up the poll. I had to delete some of the questions because you can only have 20 questions. So, but the number should be right. Number 19, if you open up the poll here, a patient has an E&M IPPE and a mental health visit on the same day, how many visits qualify to be paid at the AIR, the all-inclusive rate? And so we'll give you a minute or two. Let me look at the poll here and sort of peek at what you guys are doing. Let's see how we're doing on this one. Okay. And we got numbers are all over the place at this point. 63% of you have voted. So come on. And 72, 74. We're getting pretty close. When we hit 80%, we typically close it out because it takes a little bit long. And I'm gonna give you a couple more votes. 78%. We're stuck on 80% vote. Let's close that out, Dani, and you can give us the results.
Okay, 51% said 2, 25% said 1, and 24% said 3.
And the correct answer is 3. So 75% of you got the wrong answer on that one. It's a little bit hard because it's a completely very rare situation there. So here are here is the guidance that you get. Multiple visits on one day in general. Encounters with more than one RHC practitioner on the same day, or multiple encounters with the same RHC practitioner on the same day count as a single visit. What that means is if I come in and see my my primary care doctor, and then I come back to the same clinic, and maybe you have a cardiologist there, and it's part of the RHC, that's going to be one visit. So keep that in mind. Is even though you know that though they saw 2 different providers, it's still going to be one visit according to the RHC Medicare rules. So here are the exceptions to that rule, and this one is very rare. You have something, I go in the morning, I see my primary care doctor, and for my blood pressure, and I go home and have an illness or injury not related to that earlier visit, and I go back to them, then that would be 2 visits. You'd have to use modifier 59. It says in this slide here, it says 59 or 25. Do not use 25. Use 59. That is the modifier you should be using in that case, and that would tell Medicare to get you two visits for that. Also, if I have and Rural Health Clinic has driven me crazy, I go in and see my primary care doctor, and as well as they have that what they call the soft handoff, where I see the mental health provider and LCSW at the same time. That would be 2 allowable visits as well during the same day. And if I happen to be a brand new person to Medicare, I'm getting my IPPE physical, then and I have an EMM code on the same day, you can build that as well. So in theory, you can get up to 3 all-inclusive rates in one day. Now, I don't think I've ever seen that happen, but that in theory, it gives you the principle that you can have 2 all-inclusive rates during the same day, especially for your mental health providers as well. Okay, moving on to our CG modifier. This came into play on 10/1/2016. Let's go back to April the 1st. So April the 1st, 2016, RHCs were first required to put HCPCS codes on rural health clinics, on the UB04. Before that, you just put revenue code 0521 and you bundled everything in, and Medicare had no idea what you guys were doing. So effective April the 1st, 2016, Medicare started requiring you guys to do that. They also put out that QVL listing saying the EMM code had to be on that QVL or they were not going to pay it. And then here is some of the information that they provided for that. Here's an FAQ on the CG modifier, and there's some guidance on how to bundle your payments right there. That's about a 7 or 8 page MidLearn Matter right there that explains how to do that. And we've copied a bunch of that as well. What happened was effective October the 1st, 2016, Medicare said this qualified visit list is too complicated to keep up with. There's too many people want to add EMMs to it. We don't want to keep up with every quarter. So you guys just put CG modifier on all your claims and we'll pay them. Doesn't make any sense, isn't logical, doesn't help anybody to do that, but that's what Medicare told us to do. So you want to look through the FAQs on the CG modifier very, very closely and make sure that you understand how to use the CG modifier. By now, we're 4 years into this thing, or almost 4 years into it by now. So we should know how to use the CG modifier. I've summarized the FAQ for you guys, so we'll go through it real quickly. When bundling charges, the primary reason for the face-to-face encounter, the answer is yes. You're typically the primary reason why that patient is there, and you have an EMM code. Maybe it's probably going to be like a 99213 or 99214. That's where you're going to put the CG modifier. After dates of service, April the 1st, 2016, of course, yes. Is it what you use to report the line that's subject to copays and deductibles? That's not necessarily true, but that's mostly true. That's like 99% true. Use only when one service is provided, yes. So if you just have a 99213 on there, you're going to put a CG modifier on there. If you have just a preventive service on there, maybe you have an annual wellness exam, you're going to put the CG modifier on there as well. Use when a medical service and preventive service are furnished on the same day. The answer to that one would be no. So you would not put the CG on your preventive service. Remember, most of those preventive services do not have a copay or a deductible. So you'd want to leave that CG modifier. If you have it as an add-on or a bundled service, you would want to leave that CG modifier off, and you would not want to include those charges in that bundled line where you put your CG modifier. Is it used for the IPPE? We talked about that in one of the previous sessions. No, there's always exception to every Medicare rule. So if you do that, whatever that code was, and Louise told me the code the other day, and I completely forgot what it is. I can't remember. But for the code for the IPPE, you do not have to put the CG modifier. How often should the CG modifier be used? If you use a different revenue code, like you have a mental health service code, like the revenue code 0900, you're going to use a CG modifier on that one as well. So in the case here, question 9, do you use it when you have a medical service and a mental health service are furnished? The answer is yes. So on line 1, you would have revenue code 0521 99213 CG. And then on line 2, you'd have revenue code 0900, and then whatever that mental health service code was, 96 something something something, you'd put a CG modifier on that as well. And again, you would get paid 2 all-inclusive rates. Do you have to use it for your chronic care management code, the G0511? You do not have to put the CG modifier for that. What about nursing home visits? The answer is yes. You're going to have to use it for your nursing home visits. Is there still a QVL? Sorta. It's a guideline. What if you use an EMM code, and then this example that I gave you where somebody gets sick, they come in for the doctor in the morning and then they have an illness or an injury in the afternoon? You're going to use a 59 modifier on the second visit. And then the next question is, do you put the CG and the 59 or 25? And again, do not use 25 on there. Do you put the 59 on the same line? So the first line of your UB04 would be 99213 CG 59. No, you're not going to do that. You're actually going to put the 59 on the subsequent visit. So you would have a 99213 CG on the first line and a 99214 59 on the second line. And that's going to tell Medicare that you want 2 all-inclusive rates. Should you continue to bundle services or do what we call incident to billing after April the 1st? Yes, you are still going to be doing your incident to or bundling your charges together. Should RHCs report a CG modifier with incident to services? The answer is no. All those items that you're adding on, the 96372 for doing injection, the J code for whatever the injection was, if you did lab work, the venipuncture, you're not going to put a CG modifier on those. You're not going to put a 25 on there either. That will cause your claim to reject. Just do not put a modifier on there. Can RHCs continue to bill incident to? We call that the 30-day rule. The answer is yes, you're still going to do that. What revenue codes are valid? Pretty much all of them. They did give a listing about 4 revenue codes that were not valid, and I don't remember them off the top of my head, but it's a very, very limited numbers. Does the claim order matter on your UB04? Does not matter at all. If your CG modifier is the last thing on your UB04, the claim will process correctly. Do MSP claims use the CG modifier? Hopefully, yes. By now, 4 years later, that's probably got some mixed results there because it probably confuses them some because they're insurance companies and they like things to confuse them so they don't have to pay. Will secondary payers accept the CG modifier? The answer to that was basically hopefully. Should RHCs use more than one UB04? Should you have different UB04s and bill separate line items on each one? The answer is no, do not do it. Just have one UB04 for your service and you should be good. Does Medicare use total charges to compute your copays? And the answer to that is no. It's sort of scary. When we show you these examples, you will see that the way that Medicare does it, it inflates your charges. And you don't want your patients to be paying on those inflated charges. You want them to only be paying on the CG line of your UB04. Does the CG affect your technical components when you build a Medicare Part B fee for service? It does not. Your flu and pneumococcal, you guys got 99% of you guys got that right. Those are filed on the cost report. So the CG modifier has nothing to do with your flu and pneumococcal. What about lab? It has no effect on laboratory. Most of you guys, if you're independent, you're billing that on the 1500 form, and it's not gonna go on that as well. How will the EOB appear to the patient? It will look like your claims are inflated. That is one of the problems. There is that total number of your bill that shows up to the patient that's inflated. They will see that. So some of them may complain. They may say, "Why is my bill $500 when you gave me your bill? It said $300, but Medicare says you charge them $500." That can happen the way that Medicare is doing this. And then how to get additional information. This is that Rural Health Clinics Center website that we showed you in the earlier slides. So that's the CG modifier right there. I think it's pretty simple by now. I think most of us have sort of gotten the hang of that. It's the only thing that's new about that is for our new people, they may not know about all those rules. So here's just some general guidelines. Here's how to get your hands on that QVL listing. It's 11 pages of HCPCS codes. And do remember to report a HCPCS code for each line of service on the UB04. Include the appropriate revenue codes for all HCPCS, so you want to double check your revenue codes. Sometimes I know the MACs are very good about saying there's a revenue code mismatch when really it's not. So again, if you have problems with the edits, call me. We've got spies on the inside at Palmetto that can sort of help you get those fixed. And if we can convince them that the edit's wrong, they're pretty good about correcting them. I know we probably have about a 75% success rate with that. I do remember that the 36415, the venipuncture, is included in your all-inclusive rate, so you're not going to bill that on the 1500 form. That will go on the UB04. And again, remember your CG modifier and your claims adjustment codes. If you don't know, if Medicare gives you a rejection code or there's some type of code on there that you don't understand, if you go to Washington Publishing Company, they're the company that's responsible for all these claim adjustment codes that you see on your remittance devices or your EOBs. And so you can look those up at the Washington Publishing Company. Here is what a UB04 looks like. If we had to print one of these things out, this is what it would look like here. And here it has 81 field locators in here. Type of bill, number 4 here, 0711. This is what you guys will use 99.9% of the time you're asking Medicare to pay your bill. The statement of covered services or statement of period of time, that will always be 1 day. You do not span bill with rural health clinics. You just have it, it's going to be for 1 day. So if we had a service provided today, it's going to be 012320 through 012320. You do not span bill with the rural health plan. Even if services are provided incident to and they're over a 10 or 20 or even a 30-day period of time, use the date when you had the CG modifier, the 99213 event on there. You can also see these are places for condition codes, occurrence codes, and value codes. This is where you're going to be putting those. Those are very helpful for Medicare secondary payer. In the next slide, I will show you, I have some definitions and a place for you guys to go look up those codes for you. In field locator 42 here, this is where you can put your revenue code. Remember, these are 4-digit codes. Sometimes people will put a 521 on there. If you don't put that 0 in there, a lot of time your edits will kick you out. So same thing with your bill type. So put a 0521 for your revenue code, and then the description will be generated by your system. And here's what your HCPCS code will look like. It's going to be in field locator 44, 99213, CG. It's going to give the data service, which is going to match our field locator 6. And then this total charges, in this case, it would be, they charge for the 99213, they charged $132.50. Why they charge $132.50? I have no idea. I always like to see just round numbers. So charge $135 for it. Don't charge $132.50. So, and it's got the units of service as well. So, so that's what it looks pretty simple there. And then here's what your condition codes, your occurrence codes, and your value codes. Here's a way for you guys to look those up. Remember, condition codes relate to a specific condition typically it's the patients for Medicare secondary payer, or if you want to change charges, there's a condition code. I think it's 01 that you have to use for that as well. An occurrence code, you're going to have dates with that. You typically, when you put in an occurrence code, that's good for a certain number of certain dates. So they'll run from October 1st through 12/31. That's when those occurrence codes are good for. And then value codes, typically that's going to be when you have a Medicare secondary payer claim and they've paid you an amount. That value code you're going to put in, they paid us $90 or they paid us $50. That's what those value codes are for. And then here's the link for you guys to go in and get that. So let's keep on moving here. And then here's what, just a plain, this is a very simple one, an EMM code, 99213 CG, which we charge $100. Your copay in this case would be $20. You could collect $20 from the patient, and that's what your EMM code, that's what your UB04 would look like in your field locators 42 through 47. So very simple there. This is just a screenshot from the actual MidLearn Matters that came about on 4/1/2016. So it says here, HCPCS code from RHC qualifying visit list. That's really not applicable anymore. This was done 4/1/2016 when it was required to be there. But this is from Medicare. There's your 99213. There's your HCPCS code. At that time, they didn't have the CG modifier, so we would add that CG modifier. And then this shows them the revenue code 0300 for the 36415. They're basically showing you how to roll that up and do that. We have some better examples as we go through. Here's the example that I came up with. In our case here, we're charging $100 for our 99213. We've added our CG modifier. Notice that we put in our total charge column here $120, even though our charge for a 99213 is $100. We've added our $20 charge for our 36415 for puncture charge. We've actually added it to the CG modifier line. So now we've inflated our charges to $120. And then what will happen is our total charges that will show up to the patient will be $140. Our payment, Medicare in this case, if we're an independent RHC and we're getting the max cap, we're going to get $69.05 from Medicare, and we're going to collect a copay of $24 from the patient, and our total collections in this case would be $93.05 for that 99213, which is pretty good. That is not a bad deal. Okay, here is another example of an EMM code. and an injection. This is what we call this bundling your visit, or we call it services incident 2. And what happens is we have a $150 99214. We had an injection, administration of an injection, that's a 96372. And we charged, how much did we charge for that? $12 for that. We also gave them Rocephin, and we charged $45 for that. What we did was we added our 45 and our 12 to our 150, and we put that in the CG modifier line. So our copay will be $207 in this case. So our copay will be based upon a charge of $207. It won't be $207. It'll be 20% of $207. So that's where we get the proper copay. If you don't put these on here and you don't include those in the CG modifier line, then you don't get that 20%. So that's very important. And then here's just a summary of that was a bundle charge. That happened on the same day of the visit. This one here is the same, pretty much the same example, except for this is what we call incident 2. The services occurred within 30 days of an office visit here. So that's the only difference in these two examples here. And then let's go to the next item here, which was, this one is going to be very interesting to you. Well, what happens if you don't want to inflate your charges? What you can do is report on the UBO4 these ancillary services, or these incident 2 services, or bundled services, whatever you want to call them. Instead of charging the $40, you can charge a penny for each one of those when you put those in your HCPCS line, your CPT lines here. So the 96372, we charge $40 for it, but when we put it on the UBO4 on the line item, we're going to put only a penny. Same thing for venipuncture, same things for our J code here. We're going to charge a penny, but when we report it on the UBO4, we're actually going to move those charges, that 40, that 10, and that 10, into our CG modifier line, so we will get the proper copay. So in this case, we're going to get the proper copay from the patient, and we're not going to inflate our receivables. We're not going to report to the client, to the patient, $210.03. I mean, we're going to report to them the proper charge, not an inflated charge. So Louise and Cammi, if you guys want to chip in on this, as far, we have different opinions on this. Either way is right. Some people swear by the penny. Some people say, no, that's too complicated. We want to do our full charges. So Louise, what do you guys do in this situation?
We do the penny.
You do the penny. And how does that work for you guys?
It works better because the patients are not calling back. And like you said, they will question why Medicare didn't pay all the $500, and are you going to bill me that?
Yeah. Yeah. Cammi, is your line open now?
I think so. Can you guys hear me?
Yeah, we can hear you just fine.
Okay, great. Sorry about earlier, by the way. I was trying to use my phone. Anyway, we use another method opposite of Louise. We list out each of our codes separately. In the beginning, we did have a few, questions for patients, but we've been doing it for so long now. Our patients are just used to it. The reason we decided to go that way, it was easier with the way our software works. So I think keeping that in mind as your new folks get started, how best to utilize your software so that you get the most and you're accurately reporting your total charges really becomes the decision maker, I think.
Yeah. Cammi's absolutely right. It's whatever works with your system. There's all sorts of different systems out there, and some work much better, which is keeping the charges in there, and others work better with the penny. So it's whatever makes less work for you guys. I think in the long run is good. Dani, I see a little question mark over there. Is that something we can take now, or should we hold that for later?
You've got 3 in queue, so
let's see how we do on the questions and see are they related to what we're doing here?
That or something that you've already discussed, yes.
Oh, okay, well, let's go ahead and we'll try some questions now, and then we'll go from there.
Okay, the first one says, with an IPPE and a sick office visit, can those be done by the same provider? And do they have to make 2 separate office visit notes in the EMR?
Well, okay, read the first part of the question again. I sort of lost that.
Yep, with an IPPE and a sick office visit.
Okay, gotcha.
And those be done by the same provider.
Yes, yes. My understanding, and Cammi and Louise, y'all can correct me if I'm wrong. Does it have to? Can it be the same provider on the IPPE? My understanding is yes, that can be the same provider doing the sick visit and the IPPE, and you definitely want to keep a separate medical note or record on that to do that. Cammi, Louise, you have anything on that?
I agree with you, Mark.
Okay, all right, good deal. Good deal.
I agree, that is the best way. If not, be sure and separate it and in the one note to make sure that it is specific to, this is the IPPE, this is the sick visit.
Okay. It's so wonderful to have you guys here because that's some backup on these things here. And okay, Dani, next question.
Yep, so this kind of goes along with it. When the patient has the 2 sick visits in one day, when they come back for the second problem, do we send that in under 1 UB04 or 2?
Medicare says you can. First off, you're going to have a hard time getting this paid. Let me tell you, because I don't think I've seen anybody ever pay these things. But the Medicare rule says you can use 1 UB04. Again, use the first one as a 99213 CG. The second one, that's when you're going to put the 59 modifier on there, and they're supposed to pay that all-inclusive rate. Now, what you're probably going to get is what they call things ADR, where they're going to ask for additional information about that visit before they pay that. Is my understanding. Louise, Cammi, have you ever had one of these paid before in your life?
We actually have. Our situation was the patient had been in that morning. That afternoon, she had got dog bit and had a laceration. So instead of a second office visit, EMM code, we used the laceration repair with the 59, and we did get 2 AIRs with that.
Okay. And did you use one claim to do that?
Yes, one claim.
One claim. Okay. Cammi, do you have experience with that 59?
Yes, I have seen the 59 pay.
Okay. All right. Good deal. So okay, Dani, let's get one more question in, and then we'll move on.
Okay. Where do we need to send our chronic care management claims to, Part A or B, while no CG modifier on the claim, and how much we are going to be paid?
The question is on the chronic care management. You're going to bill that on the UB04, even though it's actually not a part of your RHC cost report because there's no face-to-face encounter. You need to keep up with that cost because it's non-allowable. What Medicare is going to pay you, last year the rate was $67.03, and I think it went down maybe 20 cents this year. So let's just say $67, multiply that by 20%, and that's what Medicare is going to pay you. And then you're going to collect a copay based upon what you charge. So if you charge $100 for that service, then you're going to get a $20 copay. You're much better off charging a low charge on that, maybe $50, and collect $10 from the patient, because a lot of people will get out if they keep seeing higher copays for that chronic care management services. So to answer your question, you're going to get 80% of basically $67. You're going to bill it on the UB04 form. You're not going to be required to use that CG modifier for that. Louise, Cammi, y'all got anything to help besides what my answer was?
We have not done the CCM at this time yet.
Okay.
I have several facilities doing it, and Mark, you're spot on. It is. I think you pointed this out, but you do bill it to Part A, and it's for an RHC, it's CPT G0511.
Okay. Yeah, I couldn't remember that. Okay, perfect. Okay. All right, let's go here. Is that all the questions, Dani?
There's a couple more.
Okay. Well, let's move on. We're gonna use up all our time here. It's amazing how fast this time goes. You think you have 45 minutes to an hour, and it goes by so quickly. So okay, here's our next example. Let's see here. Oh, this is what EKG. This is what happens when you have an EKG. Remember, I always tell people there's no globals and there's no groups in rural health clinics. So you don't bill globally. So in this case here, this is me. I have AFib, which I don't have it now, but I had AFib 2 years ago. And I had so many EKGs, it was not funded. So in fact, I was diagnosed in a rural health clinic. So if I was on Medicare, which I wasn't, but if I was, I would have been, we had our 99213, the normal EMM code just for checking me out, so what's wrong with me? And when they did the EKG, reading it to say, oh, Mark, you've got AFib, that would go on the UBO4, the technical component, the actual sort of tracing and the machine part of that. That's going to go to Medicare Part B, and you're going to get paid fee for service for that. So that's the example there. The 93010 would be added to that. It's a $100 charge for EMM, and that $25 is added to on the CG modifier line. So I think we've got that one down for line. Why is this so hard? This is patchwork software. I mean, Medicare has had this program since 1966 that we are using, I think. And so it's the same program they use to bundle everything in the UBO4. So that's why this doesn't make any sense. A lot of you people are saying, Mark, this is the stupidest thing I've ever heard, and it is stupid, but that's they're just trying to use some old stuff. So let's go into non-RHC services now. And I wanted to show you this document that came out in June of 2019. For you rural providers, there is a document that tells you how to bill a bunch of different stuff. So you got critical access hospital billing, FQHCs, rural health clinic. It summarizes all the billing that you have. So this is a great reference thing here, and it shows you where to get information for it. So I've sort of clipped and pasted all of the documents that relate to rural health clinics here. We're not going to go over all of these as we go through. We will end up touching on every single one of these things that are on this list as we go through this, what's going to be 5 hours of webinars with you guys by the time this is all over. But this is a nice one place where you guys can go look up information if you need to. And there is something about the virtual communication services, that was a new benefit in 2019, where if somebody calls your doctors after hours and they spend 5 minutes with them, they avoid a billable visit to the rural health clinic within the next 7 days. Then you can actually bill this code and you can get paid. I think it's like $14 for it. I know I was at the last National Association of Rural Health Clinics meeting. There must have been 300 or 400 people in that room, and they asked them, did anybody ever build this code before? And no one had billed it. So I don't know, Louise or Cammi, have y'all ever billed that code before?
We have not.
Yeah, I was gonna say, Cammi, have you ever seen anybody use that code?
No, we haven't.
No, it's such a rare thing that I don't, and it's $13 or $14. Most of your doctors, especially in rural areas where people hand out their cell phone numbers and talk to people on the weekends and stuff, they're not going to send them a bill for that. But it's out there. That's the only time we'll talk about that in this webinar, because it's just such a rare thing. So here's some of your non-covered services. Laboratory, radiology, technical components, EKG are not allowable charges to the RHC. So again, you're gonna push those out and bill those to Medicare Part B and get paid fee for service for that. The venipuncture is considered an RHC service, so it's a little bit. That's the sort of the thing that's the exception to all the rules. It's a lab service that you don't bill that up to Medicare Part B. Freestanding clinics, we're going to bill all these on the 1500 form using the RHC's MPI number. If you're provider-based, you're going to bill these non-RHC services using the hospital's MPI number, their outpatient MPI number, and billing those on the UBO4 form as well. And then there's the EKG billing there. So there's the codes for you guys as well. So nice information there. And here's a couple of more non-RHC services. Dental is not a Medicare covered RHC services. Some Medicaid programs will cover dental, so you want to check with your Medicaid offices there. DME is not covered. If you want to provide DME services, you have to get a provider number from your DME provider. At one point, I think it was Palmetto was the MAC for DME services, but you'll have to get enrolled and get paid for DME services through them. Anything done in the hospital is not considered an RHC. Lab, we talked about that already. And then non-covered services, again, if you're doing something that's not covered by Medicare, make sure you get the latest ABN notice, because that changed a few years ago. And if you use the old ABN notice, it will not cover, it will not count. So keep that in mind. Charges, if you do have something that the charges are non-covered, what you wanted, and you can't convince that patient, like a physical. If I go to my doctor and say, well, give me a physical. I know Medicare covers physicals. Medicare doesn't cover physicals. And so you can send in a bill type 710, and Medicare, you have to put a condition code 21 on it, and Medicare will send you a denial for that. And then here's something that Medicare Part D drugs, the injection, or the vaccination for shingles, those sort of things, they're covered under something called www.myTransactRx, and you can actually get paid for those super expensive vaccines and immunizations that you guys have. So you definitely want to do that if you're doing a lot of those expensive immunizations like shingles and whatever. Cammi and Louise, do y'all have any experience with this mytransactrx.com?
We do use it for the shingles vaccine and also for the Tdaps.
Okay. So how does that work? You basically,
You log in and it runs it under the prescription benefits, and it tells you right then how much they're going to pay and then how much the patient owes.
Okay. All right. Cammi, do you have any experience with it?
Honestly, I don't. Typically, what I hear is that our providers will give the patient a prescription.
Yeah.
Go to the pharmacy and get it done.
Go to the pharmacy. Yep. That's both ways work just fine. So that's good. Okay. Here's our next question. The 6, and Dani, if you open up the poll on this one, the 6 required lab tests to be certified as an RHC are included in the all-inclusive rate and cannot be billed separately to Medicare Part B. So there's 6 very, very basic lab tests that are required for you to be able to provide. You don't necessarily have to provide them, but you have to have the ability to provide them when your state inspectors show up. So are those billable to Medicare Part B fee for service? And we got 42% of you voted, 45, 48%. Come on, let's get a few more votes in here. Okay, we'll wait till we get to 50 seconds or 80% voted. 50, 48, and 50 seconds. Okay, Dani, will you go ahead and let's close out the poll and then see what our votes are.
67% said false and 33% said true.
Okay, so 1/3 of you've got some revenue that you can actually bill, because you can bill those 6 required lab tests to Medicare Part B and get paid fee for service for those. So it's again, your government's not always logical. I mean, if you try to use logic in a lot of these things, it's not going to work for you. You have to memorize a lot of this stuff. In this case here, those 6 required lab tests, even though it's required for you to be an RHC, it's not covered under the RHC benefit, and you can bill those to Medicare Part B and get paid fee for service for that. If you're an independent RHC, if you're a provider-based hospital, RHC with a PPS hospital, you get paid fee for service, and if you're a provider-based RHC with a CAW, you'll get paid cost-based for that. So keep that in mind, you guys. There's some revenue for suffering through these webinars. There's a little bit of gold in the pocket for you. So and here's the slide for this. Laboratory services are not covered under the RHC benefit, even though you've got a CLIA number, even though you have the ability to do those 6 required tests. There are the 6 required tests that you guys have to do. Hopefully, if the RHC Modernization Act comes about, this will go away. We're hoping that it will. We don't know if it's not passed yet. Venipuncture, they changed that in 2014. A lot of people got confused about that, and I was one of them. I was like, you got to be kidding me. This is ridiculous. But they did change that, and it's been a hassle ever since, because it's an incident to services. A lot of people will come in, they'll be fasting, they'll come back the next day or a couple of days and get their blood drawn, and you've got a $10 charge for a venipuncture that you really don't know what to do with. You don't want to hold your claim for it. A lot of people just end up eating the venipunctures from your Medicare patients because it's just more trouble than it's worth. And then there's where the Chapter 9, this is where it actually tells you what I'm telling you is the truth on this one. So we'll move on. Here's for independent RHCs, you're going to bill your laboratory on a 1500 form. You're going to get paid fee for service. There is no bill type for that. And of course, there's the venipuncture exception. And in laboratory, if you're a PPS for a provider-based RHC for a PBS hospital, you're going to use a bill type 131 or a 141. You're going to use the patient hospital provider number. You're going to bill it on the UB04, and Medicare is going to pay you fee for service for that. So, and then if you're CA, you're going to use a bill type 851, and you're going to bill on the UB04, and you're going to use the hospital outpatient provider number as well. So that's a provider-based with a CA. Diagnostic tests are not covered under the RHC benefit. This is back from Public Law 95-210, many years ago. This is from the very beginning. And I think yesterday we had a question about a sonogram. A sonogram is very similar to an ultrasound, and you will use the same sort of methodology. The sonogram will have a technical component from Medicare. You're going to be able to build that technical component to Part B and get paid fee for service for it. That interpretation of that sonogram, that's going to go on the UB04. That's going to be a part on the UB04. That's going to be a part of your all-inclusive rate. And you probably do a lot of those for Medicaid. Check with your local Medicaid agency on how they pay for sonograms, because they could have a different way of paying for that from Medicaid. Okay, let's move on. Here's your bill type for your x-rays. Typically, your technical components, those will be billed. If you're an independent RHC, you're going to bill those on a 1500 form. You're going to get paid fee for service for it. There is no bill type for that. If you're a provider-based RHC, a PPS provider, then you're going to use a bill type 131, and that's going to go on the UB04, and you're going to get paid fee for service. If you're a CA, bill type 851, UB04, and cost basis. These slides go really super fast. And then the professional piece, remember, if you use your brain, that's going to be a part of your, that's going to be a part of the UB04. And so in this case here, that's going to go in the UB04, and it's going to be billed incident to, bundled, or whatever you want to call that, but you're going to have a face-to-face encounter with that in order to bundle that and add that to that bill. So that's the reading part of it. Here's the professional piece of it. We're going to use a bill type 711, UB04, and the payment's going to be incident to. Okay, and you can't, if that's the only thing you do, you cannot bill it as a visit. It doesn't qualify on that QVL listing as being a visit. Here's how you would bill an EKG. You do not use the 9300. Remember, no globals in rural health clinics. 93005, that's your technical component. That's going to go on that 1500, like we just talked about. And the interp, that's going to go on the UB04 as well. So that one, I think we've gone over a couple times. We know that one well. Hospital services are not covered under the RHC benefit. And here's our question. A patient presents to the RHC and is admitted to the hospital on the same day. Can you bill for both an RHC and a hospital admission on the same day? Okay, let's see here. And here we come in this, we're going here. We got 40% of you guys have voted. You're going fast. Can you bill for both an RHC visit and a hospital admission on the same day? Okay, come on. Okay, we got 62. I'm gonna wait till we get 80% voted, and then we'll close out the poll. And my cat Cappuccino is purring in the background if you hear the purring. Okay, let's close out the poll now. And Dani, will you give us the results?
Yep, 64% said yes and 36% said no.
Okay, whoa. That's my cat. Cappuccino. Sorry about that. Let me go back to where we were. He moved a long ways, didn't he? Okay, here we go. How far did he go? Dumb cat. Okay. A patient presents to the RHC and is admitted to the hospital on the same day. Can you bill for both? The answer is yes, you can. So 64% of you are right. 36% of you, there's some more money for you right there. So what Medicare says is, and let's see, where is it from? Captain Axelrod. In fact, I asked her this question a few years ago. I asked Captain Axelrod, who was over the RHC program at the time. I'm not sure if Captain Axelrod is retired yet or not. She's been talking about it for a couple of years, but I asked her that question is, can we bill on the same day? And she said, yes. Send it in and let the MAC decide whether to pay it or not. Sometimes they will pay it. The only time I've seen where they will not pay it is maybe I come to see the doctor, I think I'm having a heart attack, and they admit me to the hospital. They put me in observation. It turns out I had some bad Taco Bell. and they released me the next morning, and you weren't having a heart attack, but you were in observation. Sometimes when you're in observation versus being really admitted, I've seen those two claims will cause a reject for one of the two claims. But for the most part, if you get admitted, if you have a good medical record at your RHC, and you'll have a good record at the hospital for the admission because you'll have a history and physical going on there, then you can get 2 visits for that. Cammi, Louise, y'all got any comments on that, or what y'all's experience in this situation?
Oh, I wasn't. Okay, good. I was listening. Okay.
Our providers does not go to the hospital, so we don't have that situation.
Okay, all right. Cammi, do you have any like this?
Yeah, we do. We have one clinic that does, and it doesn't happen often. We don't have a huge Medicare population there, but we don't have any issues getting paid when it does.
Okay, all right, perfect. Okay, that's what we need to know. Just your flu and pneumococcal, again, make sure you keep up with, you do not have to bill those on the UB04 or the 1500. You're going to put those on a roster. Medicare is going to pay you super well. The direct cost for the Prevnar 13 and 23 is like $170 now. So you're going to get about $300 for a pneumococcal cost, for a pneumococcal shot by the time you run through the cost report. And then for your flu and pneumococcal, for your influenza, our independent RHCs are getting an average of about $50. If you're provider-based, you're getting sometimes $60, $70 per influenza shot. So you want to do that. Your direct cost should be about $15 for the actual flu shot itself. But remember, put the patient name, HBI number, and the date of injection on a log, and give that to the person who's preparing your cost report. Ancillary services and incident to billing. We're going to go through this really super quick. I think we covered most of this already. I think you know that. Incident 2. Here we go. This incident, and this will be might be a hard one. 22. General incident to services must be provided with at least this type of supervision: A, general; B, direct; or C, personal. Okay, yeah, we'll let you vote a little bit here. 27% have voted. 45, 52. Let's let you get to 80% here. It's a close race now. It's a very close race. Okay. And 68% have voted. 70%. All right, Dani, let's close her down because we're running out of time here again. So let's go ahead and get the results on this one.
Okay, 51% said direct, 44% general, and then 5% personal. And
the correct answer is direct supervision. That is the, and here's the definitions of the types of supervision. General supervision means that the physician does not have to be in the building. It's just they're sort of over it, they have control of it. Chronic care management is something that's under general supervision. So that is something, that's why ChartSpan they have their place in Greenville, South Carolina with their 200 people that are making all these phone calls. That's under general supervision. Direct supervision means you have to be in the office. Doesn't mean you have to be in the room, but you have to be what's called immediately available. What the lawyers use is about 30 to 60 seconds. You need to be there in case of emergency. So if you're in the same facility, in your same office there, maybe you don't have to be in the same room, but you're in the same suite there. You get 30 to 60 seconds is about as long as as far away as you can be from that patient where that service is being provided. That's called direct supervision. Personal supervision means you are in the room with that patient and you've got your eyes on that patient. That's sort of like a face-to-face encounter. It's personal supervision. So those are the three categories of supervision. Here's a slide that I stole from a technical assistance session a few years ago. So direct supervision, clinic, the physician or the provider must be in the clinic, not in the same, you don't have to be in the same room. Being in the hospital is not incident to, so keep that in mind. Here's the exceptional chronic care management we just told you about, and then some of these here. We'll give you these definitions here from Medicare as well in just a second here. Sometimes the words they use, really, it's confusing on incident to, because some of the words they say don't really make a whole lot of sense to me. Things like commonly rendered without charge. We don't do anything without charging for it. So I don't know why that language is still in there. And then furnished under a physician's direct supervision. That is in the RHC manual. What that tells me is that a physician, in all rural health clinics, a physician has to physically be there in order to provide incident to services. And so here's section 120.3 of chapter 13. You can read what, so here's some of the things that are typically incident to services: blood pressure checks, allergy injections, doing prescriptions, and then nurses services, nurse only services. And then here's a description of what an incident to service is. It does not generate a billable visit, but incident to services provided on a different day as a billable visit may be included in the charges for a visit if furnished in a medically appropriate time frame. We've always used 30 days. There's no place in the regulations where we've ever seen that 30 days. That's just what everybody uses. Every seminar, webinar, conference I go to, that's the number that everybody tells me is 30 days. Okay, and then here's something that's very important here. RHCs cannot bill separately for Medicare Part B drugs or other incident to service or supplies. That means what we talked about yesterday is you cannot be billing that to Medicare Part B fee for service while you're a rural health clinic if you're providing, the Rocephin or those types of drugs. You can't bill them. That's a part of your incident to services that you want to include on that UBO for. Okay, here we go. In RHCs, here's your next question, Dani, if you'll open this up. In RHCs, nurse practitioners, PAs, and certified nurse midwives can always be the person providing direct supervision for incident to services. And let's see what our answer is on this one here. We're gonna wait. We're gonna give it a little bit of time and see what our answers are on this one. This one's okay. We're at 58% voted, 60, 61%, 64. Let's get you to 80%. 80% voted here. We'll give you up to 50 seconds, and then we will close it out. And some of you guys, are y'all looking this up on Google? So, okay, we're at 71. Let's close it out now because I know we're killing your time at this point. And the answer is false. So 77% of you guys said it was true. The answer is false. And if you don't do anything, nurse practitioners, PAs, nurse midwives cannot be that person being, you can't provide incident to services to that. If you read chapter 13, section 140, it says here, and we read this very closely because most of you guys missed this question, the direct supervision requirement is met in the case of a nurse practitioner, PA, or certified nurse midwife who supervises, furnishes service only, this is in red, only if such a person is permitted to exercise such supervision under written policies governing the RHC. You need to have written policies saying that your nurse practitioner, PA, and certified nurse midwife can oversee the direct supervision of incident to services. We have a policy that states that. We will put that policy on our website with this information as well. So if you don't have it, you can add that policy to your policy procedure manual. I've never seen anybody get in trouble for this one, but it's better safe than sorry. It is a matter of adding a policy to your policy procedure manual. That comes in our policy procedure manual, our standard template that we provide for our new RHCs, but that's what we do. So Cammi, Louise, y'all got any comments on this? I know this is sort of a weird one.
We've never had any trouble with it, and we passed our research, and she did do chart audits.
Oh wow, yeah. You're not. I haven't ever seen anybody have any problems with this yet, but it is in the regulations. It's something that's easy to fix by adding a policy. I mean, you basically just have to put a one-page policy that says your nurse practitioner can oversee that, and you fix that issue. So I don't think it's going to be an issue, but again, it's a very, very cheap insurance policy against something like that happening.
Now, in our policy and procedure manual, we do have the physician protocol with the preceptor and our nurse practitioner.
Okay, that's good. That's good. Okay, incident to billing options. Here's a couple of options that you have. One is include the charges with a face-to-face encounter within 30 days by holding the claims. If you know that Mark is going to come in for allergy shots for his cappuccino, who's being bad, then you can hold that claim until those 30 days are up and then submit the claim. Or you can send in an adjusted claim using a bill type 0717, and you can adjust the charges after the fact. Or you can just forget about it. It's a venipuncture. It's $10. We'll get a $2 copay from this. It's not worth the $2 to hold the claim. It's not worth the $2 to adjust the claim. We're just going to forget about that $2 of money, and that's probably logical. Or you could set up some non-RHC hours and perform that during that time. So we'll talk more about setting up the RHC, about non-RHC time in the future. We're running a little bit long here, so I'm going to try to get through all the questions today, and then we'll sort of get to a stopping point and start next week. But we'll show you how to do that. There's the 30-day rule. We've already told you that enough. You know that one as well. If you do want to send in an adjusted claim, you're going to use a bill type 0717. You're going to use a condition code D1. You're going to put that in field locator 18 through 28. Remember your DCN number, your document control number, or something like I hear it called the ICN number. Put that in field locator 64. And then in the remarks section, that's going to be field locator 81. You're going to put change of charges there. So Louise and Cammi, what do you guys do about incident to? Do you say you'll hold the claims, or do you adjust the claims, or what do y'all find y'all do the most?
We have a few patients, and since I know they're going to be coming in for their shots, I hold those claims, because if you do a change of charges, then you're going to have to fight the secondary insurance to get that extra copay. Okay.
Cammi, is that what you guys do?
Exactly it.
Okay. All right, good deal. All right, let's move on to the next one. Non-RHCs. Let's see here. In non-RHC hours, you're not going to go to, this is what you hear every time I go to one of these conferences. If you talk about non-RHC hours, you get people up there saying, oh, you're going to go to jail. It's so complicated. It's a cost reporting nightmare, and your all-inclusive rate will go down. The reality is no one's going to jail. This is not what's that movie National Treasure where the FBI just says somebody has to go to jail. No one's going to jail if you have non-RHC hours. It's not that hard. The cost report is designed to handle this, so it's not that hard from a cost reporting standpoint. And your all-inclusive rate will not go down if you do it correctly. You don't want to count visits that are in the non-RHC time. So if you do it right, your rate will not go down. The keys to making it work is to treat everyone the same. Make sure to keep up with your non-RHC visits. Some people will use a modifier or some type of internal code that tells them that that service was performed during non-RHC time. You want to place a sign on your door indicating the times that you're not a rural health clinic and notify whoever's preparing your cost report. Let us know that you're having that non-RHC time, so we can pull that cost out of the cost report as well. So some of the things that you want to do during non-rural health clinic time is 99214s, 99215s. Those are the high dollar items there. Do your venipunctures. You can actually bill those to Medicare Part B fee for service if you do it during non-rural health clinic time. Annual wellness exams, IPPEs. If you're an independent RHC, this makes a lot of sense because your AIR rate is going to be much lower than what your IPPE rate would be if you build it to Medicare Part B fee for service. Trigger point injections, procedures, allergy shots, nurse-only visits, and your TCM will pay up to $250 on certain codes. So you want to do those during non-rural health clinic hours. If you do that, a lot of people set up a time, maybe 8 till 9 in the morning. They're not a rural health clinic, and they will do that appointment only. And so what will happen is people will come in sort of before the walk-in part of the clinic goes, and you'll have certain appointment only things where you'll do that procedure first thing in the morning. You'll draw blood first thing in the morning because everybody wants their blood drawn first thing in the morning so they can stop fasting. These things that take a lot of time, you'll have longer visit times for these as well. That is a good way to do that to maximize your reimbursement, especially if you're not a provider-based RHC. So, okay, commingling rules here. Are the commingling rules. Basically, you just cannot selectively choose a higher or lower reimbursement rate. If something comes in, if I know my annual wellness exam and my TCMs pay more for Medicare Part B, I just can't start billing with Medicare Part B fee for service. I have to do it through this non-RHC time. Okay, finally I get to my last question here. An RHC can set aside a separate treatment room to perform procedures and bill Medicare Part B fee for service during RHC hours. So Dani, if you'll open that question up, and we'll see if we can do a magic Medicare Part B room. Okay, and keep on. What are we up to? 66% of you guys have voted so far. And you guys are right on the money. We'll give you a little bit more time and then we'll move on. And all right, Dani, let's close it down because I know we're over time already. Dani, what's our results on this one?
89% said false.
89% of you guys are right. That is absolutely right. You cannot set aside a magic Part B treatment room and have everybody walk into that room. That's that financial triage I talked about, where you look at that patient and you say, this patient needs a trigger point injection. Let's go into our magic Part B room and we're going to bill out the Medicare Part B fee for service. And then, Mark has a cold. We're going to move him over into the rural health clinic side and we're going to bill on the UBO4. You cannot do that. That is commingling at the heart. So you want to make sure that you do that. Here's the Medicare no magic Part B room. This is stuff that we got straight from chapter 13 of the RHC manual. You can have some services like you provider-based people. You can have an unaffiliated practice sort of operate through an RHC and lease a space. So you're going to have to do your cost appropriately in those cases. So keep that in mind. If you run into the situation where like this, talk to your cost report preparer if you're leasing space to somebody that's not a rural health clinic within your RHC, or if you have providers that you think shouldn't be under rural health clinic. There are ways to do it, but it's very, very complicated and sort of scary. So you want to talk to somebody. Perfect. Preventive services is where I wanted to end today, and I took an hour and 10 minutes to get there. But Dani, let's go through our questions there. We were going to start up on preventive services on Tuesday when we start these sessions back up again. Dani, do you have some questions for me?
Yes, sir.
Oh, boy.
Okay, the first one. If an incident 2 was done on January 1st and office visit on January 2nd, why wouldn't the dates on the UB indicate from 1/1 to 1/2?
Because Medicare said so.
Okay, and then it goes on, it says, if we have 3 allergy injections and 1 office visit, we would change all of those dates to the office visit date?
That's what Medicare wants you to do. Don't ask me if it's logical or not. That's what they want you to do. Cammi, Louise, y'all got anything on that?
That is what we do. Like we've got the 95115 where a patient comes in every week.
Yeah.
So the week that she sees the nurse practitioner, we have the office visit, and then we'll have those 4 units of the 95115.
Yeah, that's Cammi. Is that what y'all do as well, Cammi?
Yes, that's exactly how I understand it to be done.
Yeah. Again, don't always use logic because it's not that logical sometimes. Next question, Dani.
Okay, is there any different reimbursement with incident 2 with Medicare?
No, Medicare is going to pay you that same. If you're an independent RHC and you're at the camp and you get $69.05, whether you charge the 99213 at $100, or if you do an incident 2 services and I add a bunch to it, you charge $300. You're going to get $69.05. When you look at those RAs or your EOBs, whatever you want to call those remittance devices, you're going to see $69.05. You're going to see your rate every single visit. So you get the same amount. Next question.
But your co-insurance to the secondary insurance or patient will go up.
That's correct. That's why you do it. So if you have a $300 charge, what it's going to say is the patient responsibility is going to be $60 versus $20. So you definitely want to do it. You're leaving lots of money on the table if you don't add those incident 2 or bundled services to that UB04. Okay, next question.
Yep. Do billing processes and procedures change for our contracted lab provider if we transition from fee-for-service to an RHC?
Read that one more time?
Yep. Do the billing process and procedures change for our contracted lab provider if we transition from fee-for-service to RHC?
Louise, I think that's y'all's situation. Can you address that? Because I'm not sure how to answer that one.
Was it about the labs? Is that what she's asking?
Yes. I think you said you had a contracted lab.
Correct. We have a phlebotomist that is paid by a lab company, so we don't bill the 36415 at all.
Yeah, but you don't really do any lab work there. You have the weird thing about the rules are, and again, not logical, you have to have the ability to do those 6 lab tests. Don't say you have to do them. So what a lot of people do is they have a contracted lab and they'll have LabCorp and they do all the lab work and they send everything out. But if they need something done rapidly, they have the kits there for they have the ability to do those 6 required lab tests. So,
on the in-house, those 6 required, we do bill those, but our nurse does those. The phlebotomist just draws the blood that's sent out.
Okay. All right. I hope that answers your question. Cammi, do you have anything on that?
No, we do exactly the same.
Okay, perfect. Okay. Let's go ahead to the next question then.
Okay, if you see a patient in the RHC and then send them to the ER after a full workup, can you bill both?
Okay, so ask the question one more time.
Yep, if you see a patient in the RHC and then send them to the ER after a full workup, can you bill both?
You send them to the ER. You don't. I guess I don't fully understand the question. I think what happens is if your doctor goes over to the emergency room and sees the patient over there, then that would be definitely 2 visits. You have to have a separate medical record where you did the full workup in the RHC, and then that would be 1 RHC visit. And then you go to the emergency room and you're providing that service there. To me, that would be 2 separate visits and you would be able to bill for that. Cammi, is that the way you understand that as well?
Yes, we would definitely document it in the hospital side and make sure that dictation comes back and you put it in your EMR to justify the claim.
Okay, all right. Louise, well, you said you guys don't go to the hospital, do you? So that wouldn't apply to you guys. So, okay, Dani, give us our next question here.
Yeah. Tina Gray asks, has anyone billed the 94618 code?
I don't know my HCPCS codes that well.
It
What's
looks
the
like it's pulmonary stress testing.
pulmonary stress testing? That's probably like most things. You can sort of use a general guideline, which is if it has a technical component, it's going to go to Medicare Part B. You get paid fee for service for it. If there's a professional piece to it, that's going to go on the UBO4, and you're going to be able to bill it incident to. That would be my guess. Cammi, do you have anything on that one?
I'm not billing that code, but I would just go out to the Medicare fee schedule and check and see if there's technical and professional logic.
Yeah. Louise, is that what you would do as well?
Yes, that's what I would do. And we don't do that one, but we do the ABIs. And so that is one code, but we have to do the TC and the, is it 26 modifiers?
Yeah. Yeah. Can you, what are the TC and the 26 modifiers, Louise? So people know what those are.
TC is the technical component and 26 is the professional component of the codes.
That's right. That's right. So you want to make sure that you use those modifiers appropriately as well. Okay, Dani, you got another question?
I do. When billing medications, for example, Rocephin and Toradol, would it be more beneficial to submit as a bundled charge or use MyTransact RX?
You can't use that for that. Now, MyTransact RX is very, very limited, and they would not pay for that. Is that right? Is that right, Louise?
Yeah. The MyTransact RX are only Part D benefits.
Yeah. Yeah. So
and it's pharmacy benefits.
Yeah. So it's very, very limited. Okay, next question. That was an easy one.
Yep, and this is the last one we have so far. It says, if the patient never came back after getting an incident 2, what do we do with the claim?
The patient never, you're probably going to end up eating that if the patient never came back. I mean, you should have had an office visit if it was incident to an office visit, then there had to be an EMM service at some time. Hopefully, I'm trying to think. So you'd have one office visit, you'd have an incident to service, and then they never came back after that. If the EMM code occurred within 30 days, you could actually change your claim, you'd adjust your claim and include it on that prior EMM code. Otherwise, if they never show back up and there's not a visit within 30 days, you're just going to end up eating that claim. Cammi, is that the right answer?
Yes.
Yeah. Okay. Louise, is that what you think as well?
Yes, and we've had that a lot, but what we were told, and that may be something for your cost reporting session, is when you turn in the full procedure list, we list it there, so it kind of is washing out on that cost report.
Louise, I hate to tell you this, but it don't help you one single bit. You're wasting your time if you're doing it, because it does not go on the cost report. There's no place.
Okay.
It's no place for it. A lot of people will tell you that, especially your Macs will tell you, oh, you can put that on your cost report. There's no place on the cost report for that, unfortunately. So okay, Dani, is that all the questions that we have in the little thing there? And then
it looks like one person said that they weren't able to download the slide deck, Brian Washburn, and I actually tried emailing them to you again, Brian. So if you still don't have them, let us know.
Yeah, a lot of you folks that especially if you're in a hospital chain or hospital, your firewall will not let us send those files to you. So again, what we're going to do, we're recording this session. We'll have all, and hopefully I'll get it done tonight. We're going to have the PDFs will be on our website, and then we're going to get these recordings on YouTube, and we'll have links to that as well, so you guys can view this later on if you have new people that come and need some training. Because I think we've done a really good job. I think thanks to Louise and thanks to Cammi being here, because that really helps us to get the right answers that you guys need. Do we have anybody that opened up the line that wanted to ask a question here, Dani? Do we have any hands up?
No, sir.
no hands up. So if you want us to open your line, we'll give you a few seconds here, but I don't see anybody who wants to talk. So, okay, everybody. Well, thank y'all for attending. Louise, Cammi, thank you guys so much. We're going to have another session. I know Cammi and Louise did not sign up for this, but we're going to have another one Tuesday of next week. And if I can figure out a time, we'll probably end up having a fifth one. That way, we'll have a good data set at this point in time that we can provide for our new RHCs, and you can show them these videos and help them for their billing. So until Tuesday, thank you guys very much. Thank everybody for joining us. We appreciate it very much, and we will see you guys Tuesday. Have a great weekend.
I'm not doing it tomorrow. It'll be hell on wheels tomorrow.